One of the ways to decrease morbidity with any operative delivery is in the selection of forceps. Not all forceps are the same, and the selection of forceps depends on the station of the head, whether the baby is in an OA, OT, or OP lie, whether or not there is asynclitism present to a large degree, or hyperextension of the head. Using the correct forceps, these two can be corrected prior to attempting the forceps delivery. The gestational age sometimes plays a role, and also the degree of molding, soft tissue changes, and the presence or absence of a cephalohematoma. And as mentioned previously, the shape of the maternal pelvis may ultimately determine whether or not a trial might be attempted safely. If one follows these steps, one can truly minimize trauma for both mother and baby with forceps. The most important step is ascertaining that fetal presentation. More complications arise when forceps are applied inappropriately to the fetal head. Using forceps appropriate to the station and presentation. Using non-fenestrated forceps. Rechecking the fetal position once the forceps are applied. And if rotation of the baby is attempted, to at least start in the direction where there will be least rotation of the spine. Continuing along these lines, we can minimize trauma by correcting asynclitism. This has to be done with a pair of forceps that have a sliding lock. Under most circumstances. Make an effort to improve and maintain flexion of the fetal head. One has to always remind themselves of the axis of traction. A baby in mid-pelvis usually has to move down before it can move out. After forceps are applied, do not rock them. Simple, steady pressure, even if it takes several attempts, is safer than moving the forceps around excessively once they've been applied to the fetal head. And the key, quite frankly, is if you cannot get a good application, if this cannot be achieved or is extremely difficult to achieve, then quit while you're ahead. one can make a very good argument for actually attempting rotation in mid-pelvis. If a baby is in an occiput transverse or occiput posterior lie. Reasons for this are when the baby undergoes traction under these circumstances. If this is not corrected, usually results in further hyperextension of the fetal head and increases the risks. From an OT or OP presentation, there is also a wider diameter of the fetal head to traverse the pelvis, particularly in an OP lie. All of these factors, if they're not taken into consider, increase the risk for fetal trauma and maternal trauma. Earlier, I mentioned the use of non-fenestrated forceps. Most babies in a cephalic presentation have a pair of forceps that are non-fenestrated that are ideal for the situation. When the baby is in low position, my preference is to use Leucart, Simpson, or Tucker McLean forceps. The Tucker McLean forceps have a narrower blade and should be considered especially in the woman having her first baby or with smaller babies. If the baby is in mid-pelvis, I invariably look toward the Leucart Keelan forceps. This has a sliding lock so that asynclitism can be corrected. They have only a slight pelvic curve. They can be applied in any position. And traction can also be accomplished in any position. The slight pelvic curve makes them ideal for rotational deliveries. And the narrow blades help protect the mother in mid-pelvis. When using the Leucart Keelan non-fenestrated forceps, the risk of trauma is extremely low. In summary, despite the disfavor of forceps, taking careful preoperative steps, using proper forceps for fetal lie and station, attempting rotation when feasible, and knowing when to stop. if the procedure is not moving along smoothly, are the keys to reducing risks, reducing fetal morbidity, and reducing maternal complications.